Welcome back to another episode of The Learning Curve, the podcast where we highlight the people and ideas reshaping medical education. I am your host, Dr. Irtaza Asar. Today, we're diving into a world of medicine that rarely gets talked about in classrooms or training programs. But this is one that touches some of the most vulnerable patients we'll ever care for: incarceration medicine. Correctional facilities house over 2 million people in the United States, and this population carries some of the highest burdens of chronic disease, substance use, and trauma. Yet, clinicians often walk into these encounters unprepared, facing barriers, biases, and ethical dilemmas that don't come up in traditional training. Joining me today is an expert, Dr. Jordan Vaughn. She is the Assistant Professor of Emergency Medicine at LSU Spirit of Charity, and she also serves as an Associate Program Director. Dr. Vaughn's work extends far beyond the hospital. She's deeply involved in public health initiatives, harm reduction, street medicine, and violence prevention in New Orleans. Together, we're going to unpack the challenges of caring for incarcerated patients. We're going to explore the blind spots in medical education and talk about strategies to create safer, more equitable care, both for our learners and for our incarcerated patients. Jordan, thank you so much for joining me today.
Thank you so much for having me. Very excited to be here, so thank you.
I'm really excited to get your expertise on this topic because I think this is definitely one of those areas of blind spots in medical education that a lot of individuals don't necessarily get the training that they would want to get. I can speak from my own personal experience. I don't feel like I got the best education on this. So I'm not the only one I know in this gray zone. So I'm really happy to have you share your expertise with us.
Thank you. I'm excited.
Awesome. So let's start with a question that I'm going to pose to you. I want you to pitch it to me as to why incarceration medicine is so important and why we should devote time to its study.
Yes. I mean, where do we start? Incarceration is epidemic. We are seeing higher rates of incarceration rates across the United States, specifically and personally affected here where I practice in New Orleans or Louisiana as a state, specifically with the Louisiana state being the highest state with incarceration rates, but just nationally, we see those climbing. Unfortunately, they're climbing in women as well, where we're seeing women are being incarcerated at a higher rate. And really, just like you stated before, this isn't a standard of our curriculum. For medical school, a lot of times as we're going through clerkships or even residency, a lot of people aren't getting this content or material or exposure. So it's not until you get out into residency or practice where you may be at a facility that is kind of like deemed the facility to care for like a specific incarcerated facility, or you're just in a rural area or setting and you end up having to do medical clearances or see individuals that are being brought in for like medical exams. And I think a lot of times you're uncomfortable. You learn how to practice the medicine, but then there's kind of like this extra layer that's then added to it. And so then it can kind of make it difficult and can allow you to kind of second guess yourself in what you're doing. And then there's even the advocacy and the legal aspect that a lot of providers are uncomfortable with or physicians are uncomfortable with too. So I think it's so important to make this a mainstay, a part that's definitely a core of our curriculum, because no matter where you are in practice, you're going to care for some incarcerated individual at some point. So it's just important to make sure that you're equipped with the tools to do so.
Absolutely. And I think that's actually a great overview of why this is so important, because these individuals tend to be some of our most vulnerable population groups, and trying to help address some of these barriers, I think is really, really key in making sure that they get the best care possible. So we talked about a little bit of some of the unique needs of this population demographic, but what are some of the biggest barriers that stand between incarcerated patients and the care they deserve from your experience?
Yeah, so I think one of the things that I didn't realize until I was in training at our facility were the barriers that an individual has to even go to gain access to our system. So by the time that they get to us, I think there's a lot of misconceptions about an individual when they present to us. One, why did they wait so long to come? Two, why are they not ingrained in some medical system or on medications for, their chronic blood pressure or these are chronic ailments? A lot of times it just causes you like to question, I think originally the patient, when a lot of times it's understanding the process in which it takes for that individual to get there. So there are many barriers that come even before the individual hits your door. One being that in the incarcerated system, whether that's a jail or a prison, and we can kind of get into the differences of those if you want, but not every facility is going to have a mandated medical unit or a system or like requirement. It's very generalized. They're expected to have a medical facility, expected to provide care, assessments, and transfer individuals. But the time course, the level of care or expertise that's allowed or expected to be provided to the individuals in the incarcerated system is not mandated. And so that's going to be kind of different from each facility to another. And then secondly, I think one of the biggest barriers are you have to pay to be seen. So a lot of times people don't realize you're making cents per hour. And so, we can all complain about minimum wage in Louisiana, but specifically they are making about anywhere from 15 to 35 cents an hour working. And then when they want to go to see any individual for a medical complaint, they get charged per complaint. And it may be $2 to $3 that's required to be seen. So if you have a headache and you have abdominal pain, but you have, another symptom too, you're being charged for that. So if an individual can't afford that, if they don't have family members or support that's able to put money on their books to be able to provide that care, to be seen or assessed, it's not until they're critical a lot of times where they have to transport that individual because they're unresponsive or, critically ill or sick, that a lot of individuals are, engaging and interacting with us in the emergency department.
I think that's actually a great overview of some of the structural barriers that these individuals can face. I can speak from personal experience where I recently had an elderly female that was recently diagnosed with metastatic ovarian cancer. My resident had gone and seen the patient and came out to me and said, "Hey, I'm not really 100% sure what to do with this patient. He's currently incarcerated. And she was recently diagnosed with this metastatic ovarian cancer. And I asked her about follow-up, and she actually hasn't been able to follow up with an oncologist." I went back and I talked to her, and she said, "I just don't even know what the process to doing that is while I'm incarcerated." And that's kind of one of the more common themes that I've seen over the last several years with some of these incarcerated patients, and in relation to some of their chronic issues that they might have that potentially just don't ever get addressed. And like you said, then they come into our emergency departments or our clinical settings where, because these issues haven't been addressed, they essentially tend to propagate. And now you're already behind the 8 ball in terms of the medical management of these individuals. So I think that's actually a really great point and great overview of that. Are there certain communication barriers and ethical dilemmas that can also present themselves when we see these individuals?
Yeah, for sure. Kind of break that up into two things. Because I think it's important to take in consideration the physician provider communication barrier. And then also when you're like evaluating the patient during, the course of their stay, then on discharge. So I think it's important with communication early in the stay of an individual. And first and foremost, you have to know, one, your hospital policies. That is going to differ between hospitals. So knowing your specific policy is going to be huge. And also being familiar with like the specific laws per jail or facility that you're caring for that individual. So for example, most facilities, I will say, you as a physician are guaranteed the right to speak and talk to your patient one-on-one. So no provider or no correctional officer has to physically be in the room with you. As long as you feel safe, they may have whatever parameters they have or requirements they have, but you can always feel free and feel empowered to ask them to leave the room so that you can have a private conversation with your patient. When it comes to communication, I think that's big, especially when making sure that you can get the information that you need without feeling like the oversight is affecting the care or the information that you're getting to, do what you need to do during that course of the patient's stay. Another thing that I think is big as far as like communication barriers is at discharge. So specifically when you are discharging an individual or you determine that they're medically clear to go back into custody, if there is a specific plan for that specific individual, i.e. you need to follow up with HEMOC or you have to, take this medication, this is important, all things that are technically like suggestions to the jail because they're not necessarily deemed required to discharge the patient on hydrocodone for pain. They can give whatever pain medication ailment that they deem is the appropriate alternative or appropriate for that unit. So while you make suggestions for what you feel like that patient needs, they do not need to follow that. But I always make sure to go through with the patient. This is what you're diagnosed with today. These are the things that I want you to be taking. It's important that you take it with this regimen. These are just like you give return precautions to any other patient. You're doing the same with them. I show them the paperwork. The communication legal thing that's important is you can't tell an incarcerated individual or patient like their follow-up appointment, where that follow-up appointment is. So it's important to keep those details out because legally you cannot do that. But I do say, okay, you're seen here for this. You will and need to be following up with GI. So if 3 weeks to 4 weeks have gone by and you haven't seen GI yet, or you don't have an upcoming appointment that you've been told about that you'll need to get transported for, it's important that you talk with the infirmary or like the medical unit to make sure that that's something that they're working on for you. It's important to do that with like follow-ups. It's important to do that return precautions. It's important to do that, specifically with medications as well. I feel like when you give that information to them, to your point that you made earlier with the example, kind of allows them to be able to maneuver the system a little bit better because they have those expectations of what they need to be facilitating for them on return or like in follow up for their medical care. And it empowers them to, advocate or be able to advocate for that or their families to do so for them as well.
And I think that's actually a fantastic overview of some of the structural challenges that we have when it comes to incarcerated patients, some of the communication barriers that we face when we're dealing with incarcerated patients, as well as some of the ethical dilemmas that we can run into. And there's a lot there to unpack. And I think sometimes what can happen is residents and younger attendings can say, hey, I feel overwhelmed with all this information. So from your perspective and your experience, where do you think residents and attendings tend to struggle the most when caring for incarcerated patients?
I think honestly, it's just knowledge, specifically of hospital policy, what is within the constraints of our power, feeling empowered to make those decisions. I can just remember being an intern and taking care of some of my incarcerated patients and just being not necessarily afraid or scared of the patient, but you're just like, there's a CO there, there's two of them, they look mean, they're guarding by the door, and you're like, okay, can you please unshackle this man so I can do a physical exam and take off his jumpsuit? And just you're like, hi, I'm just an intern, but I need you to do these things so I can care for the patient. So it just feels weird initially and then very intimidating. But I think once you feel empowered to know what your rights are to ask for as a physician, and then also what the patient's rights are, then it allows you to care for the patient better, right? And then over time, you're going to get more comfortable.
And your experience there really resonated with me because as an intern, I remember coming out of the room, looking at my attending, and I'm like, hey, I'm not really sure how to do a discharge plan for this situation.
Yeah.
What's my discharge follow-up? Am I allowed to talk in front of the police officers that are there?
Yeah.
What do I do with regards to the handcuff? These are all things that I never got formalized education on. And I think that's really a huge blind spot for a lot of individuals out there. So I think that was a great point that you were just bringing up there.
Yeah, I think the biggest thing is just feeling empowered. And you can only do that if you know, right? Our specific hospital policy may be a little bit different from the hospital policy down the street. But for a lot of times per state, you're going to have per federal roles, you're going to have a lot of a similar same policy. So I think just becoming familiar with them is really important just so that you can advocate for yourself as well as a patient. And then I think the other biggest thing is during that patient's stay, caring, assessing that individual and being able to do that just like you would with any other individual and standardizing things. It's already going to feel awkward. It's very different for a lot of ways, but I think the more so you can standardize that to approach and treat that patient just like you're treating any other patient, that's when things get easier and things flow a little bit. And then it's just the specifics to your point of on discharge. You may have to remember for jail, and I'll kind of get into it just because it matters specifically for discharge. But if someone's in jail, it's important to know that if they're in jail versus if they are incarcerated in a prison. I say that because if they are in jail, there is a possibility that that individual may know their sentence, they may know their release date, they may know if they're going to make bail. So it's really important to, if an individual is in a jail, ask them, hey, do you know when you're going to get released? And if so, I'm going to send paper scripts with you so that when you're discharged in 1 or 2 weeks, you have those paper scripts when you are released, and then you can go to the whatever facility, pharmacy to fill those medications. Another thing is that once an individual is discharged or once an individual is incarcerated, they lose their rights and qualifications for Medicaid. So in realizing that, once someone is, discharged or released, they likely would not have Medicaid or the same insurance that they had before because they're going to automatically disenroll them. So at that point, it's really important if you know that someone's going to be getting out soon, even from jail or even from prison. They may say, hey, I have a release date in 2 months. If you're familiar with certain, locally here, we have what we call the formerly incarcerated clinic. And there's a lot of other clinics nationally that do something similar. But they'll work with individuals with case management, job resources, mental health, things to just kind of help them acclimate as they're released and they're acclimating back to being back into society. Know of facilities like that having different discharge phrases or smart phrases to put in that individual's information so that when they are released, they get that paperwork will help them acclimate a little bit better and transition back into the medical care system once they're discharged.
Excellent. I think that's a fantastic overview. You really tackled some of the issues and blind spots that our learners and us as attendings can face when dealing with incarcerated patients. So we've established where some of these blind spots are. And now, from my standpoint, let me ask you a follow-up regarding this. How do we start addressing these issues in training? What's worked for you from your experience when teaching residents and students in these encounters?
I think it's multiple things. First and foremost, it's getting more popular now, but I think talking a lot more about disparities, something that we just didn't talk about before. And I do see it kind of becoming more implemented into like medical student curriculum. But I think just very early realizing that different individuals are going to be more susceptible to incarceration, just like any other medical ailments that we learn about, those are going to be the case for the individuals that we see in the incarceration system. And so I think introducing those things just as early as medical school is really important. But I think in residency, I try to like ingrain a lot of our social determinants of health, case management cases that may be a little bit difficult when it comes to like discharging and adding that extra like layer on top of medical cases when we're doing simulation, just so that's ingrained and you're having topics and conversations about how to do that. On shift is another great way or opportunity, kind of to your point where you felt safe and vulnerable enough to go up to your attending and just be like, hey, look, I don't even know where to start with this, right? And your attending may have known just from experience or having done it before. But a lot of times, to your point, many of us don't, and we're not familiar with how to do this. So I think just being vulnerable and knowing when to ask for help, case management typically is a great resource in our hospitals. But I think on shift teaching, simulation curriculum is great. Of course, didactics, we call it patient safety conference, but morbidity and mortality, always kind of adding a slide on the social determinants of health that like have impacted patients that were involved that you're discussing is also another great way kind of put that into our curriculum during residency. And then of course, didactics. We have another professional that's currently local that does a lot of incarceration health and like the medicine and med peds world who will come and come to our didactics and also give lectures to residents. So I think integrating that into core curriculum is really the only way to make sure that people are exposed and that they feel empowered and they have the information that they need whenever they see that patient practice.
Absolutely. One of the other things that I've gotten in the habit of is trying to take that trauma-informed lens approach towards tackling some of these patient encounters that we might come into. And also just trying to navigate through some learner biases and trying to make my learners aware of the fact that, hey, listen, your bias might be affecting you in terms of how you're trying to manage this patient. I can talk about a recent encounter where a resident came out and said, hey, I think this individual is ready to go. And then I went and saw their respiratory rate was in the 24s, 26s. And I said, hey, I get that we're trying to get them out and trying to, move patients. But at the same time, this individual who's in handcuffs, who's been here for about 3 hours, their respiratory rate has never been under 20. Should we consider PE on our differential? Should we consider other things that could be driving all this? Because you walked in that room and you already have this bias that, hey, listen, maybe this patient is trying to just avoid going back to their site of incarceration or something else along those lines. You're not really considering the full differential in this picture. The resident went back in, talked to the patient, and came back out and said, hey, listen, there are some risk factors here that I'm concerned about. And I've realized that innately I had some biases that I went in with, and that's where some of these issues can also stem from. And I think your idea about simulation cases, I think, is so valuable because really we can start to implement that and create encounters that can allow our learners to get more comfortable in these situations and to navigate some of the idiosyncrasies that can pop up and also certain challenges that can happen from a communication standpoint. So I think that's all really, really valuable. One of the things that, Jordan, that you had talked about was talking about strategies for learners, but what about for the system as a whole? How do we start moving towards safer and more equitable care for our incarcerated patients?
We could we could be here for days. Definitely advocacy controls everything. It controls law, it controls access. I talked a lot before about mandating or having like a standardized like medical system. Different organizations and national organizations like SAMHSA are making harm reduction required for, CEOs to be trained on recognizing like overdoses. So I think we're moving in the right direction, but I definitely think that there needs to be more of like a federal, state, as well as local push advocacy wise to make these things required. Because when you don't, then it's left to the jurisdiction, unfortunately, of individuals that just have other motives and, it's not a priority for them. As an emergency medicine provider specifically, like we see the most vulnerable. We see people on their worst days. We're caring for those that other hospital systems or, others aren't able to access or receive care through. So I think that's why a lot of us are attracted or to the specialty. But I think because of that, it's just really important to place emphasis and energy towards your local or even federal national policy. Just those policies that are going to make a difference when it comes to the things that are negatively impacting us when we're caring for these patients. I think that's really pretty much the best place to start. You can do all these initiatives outside of the emergency department, increasing access and communications with our jail system, calling the infirmary when there's no notes that are coming with a really critical ill patient to say, why are you sending this patient here? I have no idea where to start. Like, help me, help you,
Yep.
and our patient. And getting us. So I think, things that we don't always necessarily do. We call family all the time to get collateral, but feeling kind of empowered to do that with the jail system too, because it's, just a similar thing, just a different scenario where you have to get that information for your patient to be able to care for them in the best way possible. So I think, it starts individualized at the bedside, but then I think always feeling that physicians have that right space and advocacy, tell our stories because they matter. And if we're not telling our stories, then those that are making laws and policies don't have the collateral that they need to really impact change or, things to take into consideration when passing those laws.
Absolutely. I think, again, that was another fantastic overview. Now, let's say if I'm designing a curriculum to try to navigate through some of these challenges, I'm trying to think about advocacy. I'm trying to think about all the incredible things that you've articulated during this episode. Are there particular resources that you would recommend that I can use or incorporate to build my curriculum?
Yeah, for sure. So when we talk about a lot of like the basic rights, one website that I want to highlight is Scopes and Shields. I think that they are a great resource when it comes to just what are my rights? Like, what are the basic rights of a physician, a provider, and then my patient when they come in? And it's just a great overview, kind of like question and answer, fact, myth buster. That's a great access tool. Different organizations, so when it comes to harm reduction, I highlighted them before, but SAMHSA has great harm reduction like guidelines that are already made, so that if that's something that you're interested in from like an advocacy standpoint, or even something that you want to implement in your local prison or jail system, that's definitely a great place to start. And it's already created, it's done. It's a suggested guideline, so you can really just use what they have and adapt it to your local program. That's another great source. And then, of course, CDC has a lot of guidelines as well as far as just understanding the disparities surrounding those that are incarcerated, but then also some recommendations as far as local as well as national programs that are like advocating for those individuals just to get a current landscape of what's currently happening in that space. I think those are the few resources I would say are probably a really good place to start.
Perfect. And what I'll do is I'll link some of those in the show notes for any of the listeners that are interested in trying to revamp their curriculum with regards to incarceration medicine. You guys will have access to those. So as time is ticking down, one of the questions that I ask every single one of my guests is, hey, if I'm a first-time listener, what are the 3 key big takeaways that I can take away from this episode?
I feel like I am being a dead horse here, but my first one would be we are lifelong learners. This is going to be new, as you already heard when we started this podcast, for everyone. I myself still learn something day to day when caring for incarcerated patients. So definitely, I think just realizing that the adage of us being lifelong learners is true. Just taking it day by day and learn what you can from each patient so that you can take care of and advocate for the next patient being better at first. Second would just be being familiar with hospital policies. So know your hospital policy at your hospital. Also be familiar with your local jail or prison systems that are local that bring patients to your facility. Just be familiar with, even if it's just the contact information for their infirmaries. Just, I think those basic things and information can be helpful in caring for your next patients better. And 3, just be empowered. Advocate for yourself as a provider. Know that you have rights to care for that patient in the best way that you can. That's why you went to medical school. That's what we take the oath to do. To feel empowered in doing that. Was advocating for your patients and empowering them to advocate for themselves. Those would be my 3.
Awesome. I love that. And I've learned a lot from this episode because, again, I never got formalized education, and I know I'm not the only one out there. This is definitely a blind spot for not just residents, medical students, PAs, nurse practitioners, program directors, other attending physicians. So, Jordan, thank you so much for shedding light on this topic and giving us a lot of great insight on this. One of the things that I wanted to pick your brain about is there anything that I didn't ask you about this topic that you would just want to have a platform for and articulate or say?
No, I mean, I think you mentioned this, and I just want to reiterate that, the patients that we're caring for that are incarcerated are the most vulnerable. And I would really like to make sure that we mentioned our biases. You have them, I have them. Everyone is going to walk into a room with their bias. So it's just really important to realize what our specific biases are we can be aware of those and make sure that we are addressing those biases as we're caring for patients. And that goes for the incarcerated population, that goes for any population that we're caring for. So I think we hit that, but I just really want to make sure that I leave that with everyone here as we practice, is that no one's perfect. It's not a guilt or a blame game or to say that you're a horrible person because you have this bias or viewed this way. We have them because of the way we all grew up, and we all grew up differently. So I think just realizing that and practicing, and just being humble and understanding that we have them and just being aware of our biases so we can care for the next patient better. I really want to reiterate. And I know we said that, but would be my one thing I'd like to leave everyone with.
Yeah, absolutely. And I think that's a great point. Even going back to that story afterwards, the resident used the word, hey, my biases got the better of me.
Mhm.
And when he said that, I was like, hey, you know what? That takes a lot of insight to actually recognize that. Whereas other individuals might just say, hey, listen, no, I didn't miss anything. I'm totally fine with the way I am. But to
Right.
have that level of insight, I think is so valuable. And
Right.
I think your point is really valid. The more we can recognize our own biases, the better we can understand some of the limitations that we have
Mhm.
and try to address them so that we can be better clinicians. So that was fantastic. Jordan, is there any social media where folks can reach out to you to connect with you to talk about incarceration medicine and some of the nuances that might come with it and get your insight on those topics?
Yeah, of course. So on Instagram, I'm at JAY_NEI. So feel free to always reach out to me on that platform. I'm also on LinkedIn as Jordan Vaughn, so you can always contact me that way. I'm happy to reach out to anyone, and then I'll send my email and then show notes so that if you want to reach out to me just in regards to curriculum, grant rounds, any conversations that you're having as far as trying to develop a curriculum at your own institution, I'm happy to speak with you more about how to do that.
Perfect. And I'll include all those in the show notes. And I'm really excited to actually go through some of the resources that you've recommended. So this has been a fantastic episode, Jordan. Thank you so much for joining me and again, giving us some well-needed insight into this topic and talking to us about all our biases and how we can try to better address them as well with regards to this vulnerable population demographic. So this was a fantastic episode. One of the questions that I want to leave to our listeners is, we talked a lot about incarceration medicine and what Jordan's done, but what work have you done to incorporate that into your curriculum? How have you integrated some of these ideas in terms of your residents, your medical students, and what have you done to try to tackle some of these barriers? Let us know so we can keep the conversation going and we can try to become better clinicians. Thank you so much, Jordan, for joining me. It was a pleasure having you.
Thank you.
For all the listeners listening, follow us on YouTube, like us on YouTube, follow us on Instagram. We're on Apple and Spotify. Thank you guys for joining me for this great episode. Looking forward to keeping the conversation going. See you guys soon for the next episode.